Okay. So I'm not going to discuss about like all the basic things because you are doctors you are doing in next week exam. You don't need to understand the basics because you already know like what are the basics. This I made this for like for from the beginners to the experienced doctors. Okay, but I will explain about those waves. Okay. So in the ECG we know there are different. Yes, yes, doctor. Yes, Dr. Grace, that is true. Yeah. Okay. So here, what do ECG waves? So what do you know about waves? Okay, first I will explain. So this is our heart, right? Heart and we have SA nodes and we have AV nodes and we have other conduction system, right? So SA node, what is happening? There is electrical impulse generated in the SA node, right? Auto stimulation happen. Then these impulses are uh, generating the node and they are going through this atrium, right? So once they are going through this atrium, so we can see the P waves because of the atrial depolarization, right? These waves going through the atrium, then there is a P wave formation. Okay, that is that. Then so after these waves reach into the AV node, right? After these reach into the AV node, what happened? The AV node also getting stimulated, right? Then what you can see, doctors. Tell me, doctors, what you can see. Here the impulses reach AV nodes and here is delayed before passing to the Purkinje system and ventricle. So then this stimulus, these signals pass into the AV node, then it go into the Purkinje system and throughout the ventricle. This is the system that we are talking about right here. Here, why there's a PR interval? Because there's a small delay in the impulses that they are reaching to the AV node, then the processing, and those things happen in the AV node. That's why we have PR interval. So, what is QRS complex? QRS complex see an impulse travel rapidly through the Purkinje system, causing the ventricular depolarization. After reaching the AV node, these signals are going past through the Purkinje nodes and throughout the ventricle, then we can form the QRS complex. This whole the complex that QRS, that means the ventricular depolarization, right? So like that. Then what is ST segment early phase after ventricular depolarization, right? So ventricles are fully depolarized. Atrials are repolarizing, but is hidden in the QRS complex, right? So what is T wave? T wave means the ventricular repolarization. So they have depolarized, then ventricles are getting repolarization. Then we can see the T wave, right? Then we can see the T wave like QT interval mean the whole the total ventricular depolarization with repolarization, right? This is the like the general basic idea of these the waves and the intervals, right? Okay. So I hope you get the idea because it's very easy. Then you know the mechanism, then you can easily understand. If there's a P wave is missing, you can understand. Okay, so what happened? The atrial depolarization is not happen, right? If the P wave is missing, right? Like that. Okay, so you can think according to that. Okay, so you all know we are using the 12 lead ECG, right? We have lead bipolar leads. We have lead 1, 2, and 3. The augmented leads we have AVR, AVL, and AVF. Then we have chest leads V1 to V6, right? These are the leads that we are using. So when we understand, especially the MI, right? We need to understand. Wait, what is in the chat? Yeah, I will upload, doctor. Yesterday also, I delay my, I had to go to the bank, but I was waiting till it's uploading because, the August doctors are very stressed and I don't want to stress anymore. Because of that, yesterday also I quickly uploaded, till I was waiting. Then I went to the bank. Today also I will quickly upload, okay? So don't worry about it. I don't want to stress you anymore. Okay, so we are discussing especially the MI, because MI is not only the throughout the heart. Like there's a specific location. For that, you need to understand which leads are showing the those area of the heart, right? So if it is septal V1 to V2 lead, especially you can see. If it is anterior V3 to V4, so we are usually like taking this anterior septal together. So anterior septal, we are taking V1 to V4, right? If it is a lateral one, 1 AVL and V5 to V5 and V6. So if it is inferior, you can think 2, 3 and AVF, right? These are the things that you should remember, okay? So by heart, you have to remember those things, right? Okay, like that. So yeah, yeah, the same thing, doctors. Okay, same things here, same thing. So yeah. So we all know heart rate is 60 to 100 beats per minute, right? So rhythm is usually we are checking the to get the idea about the rhythm. We are checking the RR intervals, right? Regular RR intervals. Usually that means it has a rhythm, right? If it is a irregular rhythm, that RR intervals are varying, right? RR intervals are varying, and here's the ECG, the normal durations. So P wave duration usually less than 0.12 second, right? 0.112 seconds. So I hope everyone know like this is clearly. If you not, please take a screenshot and remember these the values. Okay, those are very important. Those are very important. So yeah, I'm not going to explain the wave wise here. So here, once you see the ECG, how you should interpret it, but don't take this like too serious, because you are getting the not only the single ECG. This interpretation is very useful. Like once you are in the med school, right? Those things. So like we are solely like solving the ECG only question, because in the exam you are getting a clinical scenario. Like while reading the scenario, you will get the idea about what is happening. Then you will get the ECG, and then you can diagnose. Like everything should be done in within 1 minute during the exam. Okay, so but usually this is the usual way: the rate, rhythm, P wave, PR interval, QRS duration, the axis, ST segment, T wave and QT. Those things we are doing. Then after we are checking the what is the diagnosis, if patient is unstable or stable, right? What is the next management step? Like that's the way we should usually go. So we'll start from different pathologies, right? So atrial fibrillation, what you can see in the atrial fibrillation, ECG doctors, atrial fibrillation. Quickly, I will go through these things. Tell me. Atrial fibrillation, what you can see. So once you think about the atrial fibrillation, I always telling you to remember I rhythm. If you see I irregular rhythm, think about atrial fibrillation, because sometimes they are not given. The patient is having atrial fibrillation, and atrial fibrillation are given in different scenario, like so like associate with the other diseases, like a lot of things they are given. Because of that, mostly they are given I rhythm, right? I mean irregular rhythm. In that case, think about atrial fibrillation, right? And what are the other things you need? There's a no P wave, right? P wave is absent, right? And there can be fibrillatory waves, right? Then variable RR intervals. QRS usually narrow unless there's another conduction abnormalities here. Irregular rhythm. So like once you need to get the proper idea about the ECG and everything, so just type atrial fibrillation LIFT, life in the fast lane, then you will get the better ECG, because the best guideline to go with the ECG for the Australian guidelines, I will suggest the life in the fast lane LIFT, because they have the ECG basics as well. I'll show. That is very important. ECG basics. So you can find everything there. Okay, ECG basics here. You can just, as example, okay, here the T wave. Then they will explain like what is the T wave characteristic, abnormalities, when T wave, then hyperacute, like everything about T wave they are given. Because of that, I can prefer this is the best guideline, especially this is Australian, and you all can use this. Okay, like I'm telling this during the exam, because once you get the ECG question and you don't have any guideline, just type in the LIFT, life in the fast lane, with the exact the name of this is, then you will find this out. Okay, that is very important. So no P wave, absence of isoelectrical baseline, variable ventricular, QR is complex, usually narrow, less than 120 millisecond, unless pre-exciting bundle branch block association, right? So fibrillator wave may be present and can either find amplitude less than zero point 0.5 or cause amplitude more than 0.5 millimeter. Fibrillator wave may mimic P wave. So once you see the fibrillator wave, you can think it as the P wave, but it is not. Okay. You can see, right? Irregular. RR intervals are not same, right? Irregular rhythm, not in isoline either, right? So variable ventricular rates, absence of isoelectric baseline, no P wave. So this is atrial fibrillation. And this is another example, irregular ventricular response, fibrillator waves visible in V1 here. Yeah, you can see the fibrillator waves, right? Here, fibrillator wave, these are, right? Okay. So, what is atrial flutter? How the atrial flutters can see atrial flutter. Atrial flutter, you can see the narrow complex tachycardia, right? Regular atrial activity around 300 beats per minute. Loss of isoelectric baseline, and you can see the sawtooth pattern, right? Sawtooth pattern. Can you see the sawtooth pattern? The sawtooth pattern, right? The sawtooth pattern. That is very important. Sawtooth pattern you can see. Right, so tooth pattern you can see here. Then here upright flutter waves in V1 that may resemble P waves, right? Always like there can be a mimicking P waves as well. So because of that, think about it, right? Here, upright flutter wave in V1 that may resemble P wave. That is the one thing. Then ventricular rate depend on the AV conduction ratio. So what is this ratio? Because in the flutters we have ratios, right? So what does that mean, these ratios? Okay, what is 2 to 1 block mean? What does that mean? Tell me, doctors. So what is this AV conduction ratio? Can someone explain? What is it? So here AV conduction ratio mean what? The ventricular response, okay, here. Okay, here they have not mentioned, so but I will explain. AV conduction ratio mean like how many atrial impulses. So, what is the wave that you can see in the atrial impulses? Atrial impulses mean which waves? Atrial impulses mean which waves, doctors? Atrial impulses mean which waves? Okay, atrial depolarization. You can see in which waves? P waves, right? Yes, it's P waves. So ratio AV conduction ratio means how many atrial impulses, that means how many P waves occurs for each ventricular response. So ventricular response that you can see in QRS, right? QRS. So that means they are like checking how many P waves having for each QRS response, right? Each QRS wave, right? That is simply I can tell as a AV conduction ratio. So what does that mean? 2 to 1. 2 to 1 mean what? That means 2 P waves for 1 QRS, right? 2 P waves for 1 QRS, right? Yes, that is the simplest way. That is very important. Otherwise, like you will be confusing. Don't confuse. This is the easiest way. Remember how many P waves for each QRS, right? So that means 3 to 1 mean 3 P waves for 1 QRS, right? That is the way. Okay. Okay, here. Yeah, that is the things. Okay, here atrial flutter with 3 to 1 block. What does that mean here? Atrial flutter 3 to 1 block. Tell me, doctors, what does that mean? Mm-hmm. So here, what we have? Here we have which waves? Here we have, doctors, what? F waves, right? F wave, right? Mm-hmm. So, because in flutters, we don't have the proper P waves, right? We have what? We have F waves, right? Right, the flutter waves, right, doctor? So, in here, 3 to 1 block mean what we have? One, two, three. Three F waves for this one QRS, right? Right, doctors? One QRS, right? Right? Do you understand? Got it right? Okay. Mm-hmm. Yes. Please understand, okay? Because like the usual, the normal P waves are absent, but I explained AV block mean that generally, okay? Usually we are using the AV conduction ratio with the P waves, but here we have the F waves, right? Okay. So keep in mind because we are getting the flutters. Flutter always has this. They are giving in this ratio thing. Because of that, you need to understand that thing. Okay. Yeah, here also flutter. Here, what type of flutter you can see? Here they are giving the 2 to 1 block. Here, can we see 1, 2, then here 1, 2 here. Yeah, but it's not very clear. Okay, here you can see. Not very clear. Okay, here 1, 2. Yeah, here 1, 2, like that way. Because it's not very much clear. Okay, 1, 2. Yeah, can see, like we can understand 2, 2. Here inverted flutter waves in 2, 3, and okay, let's see 2, 3. These are inverted flutter at rate of 300. Upright flutter waves in V1. Okay, yeah, V1 you can see upright flutter waves. 2 to 1 AV block resulting in ventricular rates of 150. Note that occasionally irregularity with 3 to 1 cycle in V1 to V1 to V3. V1 to V3. 3 to 1, 1, 2, 3, but it's not very visible like a 3 to 1, right? Okay, it's fine. Just get the idea. Get the idea. Okay, get the idea. This is the way. 3 to 1 block. 1, 2, 3. Like that way. Because sometimes it's like hard to understand in there with the F waves, right? So that's why. Okay, so I have selected some questions. This is like we have 185 questions in e-medicine for the ECG. Right? I have selected the questions with pictures. So not everything from 100, from 105, I have selected these questions. We will do after this, okay? We will do after this. Okay, so yeah, like that way. So here, sawtooth flutter waves you can see at the breast appreciated in 2, 3 and AVF and V1. Atrial rates commonly around 300. 2 to 1 conduction. Okay, here the ventricular rate, okay, around 150. Okay, this is the way you can see the F waves and flutters. Okay, so SVT. SVT doctors, how SVT present? So SVT, we have narrow complex tachycardia, right? The rate is around 150 to 250, right? QRS is narrow, less than 120 millisecond. That's why we call narrow complex tachycardia, right? P waves may be hidden with the QRS or appear retrograde the later after the QRS or sudden onset his termination are typically okay. Here the rate and heart rate is more than 150, and you can see the regular rhythm, right? The narrow compressed tachycardia and the RR intervals are regular, the same. So that we call regular. So P wave real visible. They are not like directly absent. Real visible. Okay, partial or complete varied within or at the end of the proceeding. So sometimes it can hidden inside the QRS complex or it can hidden inside the T wave. Okay, so QR is usually normal or narrow, basically narrow, okay? Basically narrow, less than 120 millisecond, maybe wide if there is a pre-exciting bundle branch pro. This is the way you can see. And here you can see the SVT, right? So here, narrow complex tachycardia with the same rate. Okay, here like that. Narrow complex tachycardia. Next, ventricular tachycardia. Ventricular tachycardia, you have here what you have. Usually, it's also regular, and you can see this is previous one SVT, supraventricular tachycardia. That is a narrow complex, but in ventricular tachycardia, that is what? That is a broad complex tachycardia. It's broad, right? Usually QR is more than 120 millisecond and it's regular. AV dissociations can be seen. Okay, now tell me what are the two types of ventricular tachycardia? We have two types of ventricular tachycardia. Tell me what are the two types of ventricular tachycardia? Okay, according to their time period, how we like categorize them, because that clearly mentioned in the TG. Sustained and so sustained. Okay, sustained mean what? Sustained mean what, doctors? Sustain mean what? Okay, here. Non-sustained and sustained VT, very important. Okay, non-sustained mean more than three ventricular beats last in less than 30 seconds. Less than 30 seconds mean non-sustained. Sustained mean last in more than 30 seconds or require early termination due to hemodynamical. Just remember the last more than 30 seconds. Okay. Last more than and like non-sustained is less than 30 seconds, usually asymptomatic coincidental, but sustained we have the palpitation, chest pain, dyspnea, pre-syncope, those things can be associated, right? So remember these two things. And other than according to the morphology, we have different types of VTs, right? According to the morphology, how we categorize VT types. Tell me, doctors. We have what? We have monomorphic VT and we have polymorphic VT, right? So monomorphic means what? All QRS complexes have the same shape and same axis, right? Monomorphic. 1 minute, I have attached. Maybe monomorphic. No, this is. Can you see? Every QRS complex is having the same morphology, right? Same morphology. Yeah, I'll show the polymorphic. Okay, monomorphic and polymorphic. Can you see monomorphic? Monomorphics, polymorphic with QR shape and axis continuously change, right? Continuously change. Here, one thing, there's other thing, right? Like that. Sometimes, like in the same ECG, there can be like earlier monomorphic and other later. Then there can be some. It can be differentiate to the polymorphic as well. Okay. So this is just remember. And like if this polymorphic VT associate with the prolonged QT, what you can see? What we call polymorphic VT with prolonged QT. Tosade, right? Tosade's point is right. So yeah, that is very important. Okay, here. Okay, sorry. Yeah, in here also, like in this area, we can see the monomorphic, but here, like kind of pattern has changed, kind of polymorphic area we can see, because in the same ECG there can be monomorphic and polymorphic weight in the same patient. Okay, yeah, okay, so yeah, that is the thing what we can see. We just discussed broad complexes. Can you see more than 120? Here, the classic monomorphic VT with uniform QRS complex, but here they have changes, right? You can see V1, V2, it has changed, okay? But here, this area, and AVF and the 2, you can see the monomorphic pattern, right? That's not very important, but just to understand the classification, okay? So, what is ventricular fibrillation? Ventricular fibrillation, doctors? What is ventricular fibrillation? Tell me. Very important. What is ventricular fibrillation? What is it? What is ventricular fibrillation? It's what? It's a cardiac collapse, right? It's a cardiac collapse, doctor. Complete chaotic electrical activity, no identifiable organized P wave or QRS complex or T waves, irregular waveform. It's a shockable cardiac arrest, right? So in the VF, there's a no effective ventricular contractions, no cardiac output, no pulse, sudden collapse, and the cardiac arrest can be happen, right? Cardiac arrest can be happen. Okay, here. Ventricular fibrillation. So, chaotic irregular deflections in varying amplitude, no identified P waves, QRS, or T waves, rate 150 to 500 per minute. Amplitude decrease with the duration. See here, can you see that there's a no rhythm, no pattern, irregular, no any wave pattern, no any segment. Sorry, nothing can be seen in here. Here, can you see we can't find any pattern here? Yeah, and we have like a fine and fine VF. This is kind of better than this one, right? We call it fine VF. Anyway, VF is very dangerous, right? Dangerous mean like next moment, if you are not doing anything, the patient can be dead, right? It's a cardiac collapse, right, doctors? Okay, and it's a shockable cardiac arrest rhythm, right? Shockable one. Okay, so next one. Next, we'll discuss about long QT syndrome. What do you know about long QT syndrome? Long QT syndrome, doctors? Long because I'm not explaining the the management because we can get the management while doing these questions. Okay, tell me what do you know about long QT syndrome? What do you know about prolonged QT interval is the key finding, right? How long? How long, doctor? The long QT mean how long? Mm-hmm. Usually, usually more than 450 millisecond, right? 450 millisecond. 450 millisecond, right? 450 millisecond. Okay. Very important. Remember those things, right? If it is a more than 500, that is like high risk for Tosade pointers, right? Very important. Very important. The key, remember these 450 millisecond. Okay. So QT extend from a start of QRS into T wave, right? We know like what is QT. Everyone know, right? Yeah, QT should be corrected for the heart rate. So may have abnormal T wave morphology, including broad notch or biphasic T. I'll show here. Oh no, I have not attached anyway. So may show the T wave alternance in marked QT prolongation predisposed to tosality pointers polymorphic ventricular tachycardia, right? Okay, so here what are the causes of long QT? What are the causes of long QT? Tell me, doctors, causes of long QT, long QT syndrome. There can be congenital, right? Congenital long QT syndrome we have. So we have acquired from drugs, antiarrhythmic, antipsychotic, some antidepressant, right? Some antibiotic, the macrolides kind, right? And there can be due to hypokalemia, hypomagnesemia, hypocalcemia, all the hypokalemia, hypomagnesemia, hypocalcemia also can be a cause, right? So how it present? Patients can have the palpitations, syncope, right? Seizure-like episode, and there can be sudden cardiac arrest as well, right? Sudden cardiac arrest as well. Yes. Mm-hmm. Yes, okay. So torsade, polymorphic ventricular tachycardia, QRS complex appear to twist around the baseline, usually associated with prolonged QT, right? Drugs and the hyperkalemia, those things can be the same here. Can you see? Torsade pointers, right? Torsade pointers. Okay, let's discuss about the AV blocks. So what do you know about AV blocks? AV blocks, we have different degrees, right? AV block, we have first degree, second degree, and third degree. Second degree, again, we divide into morbid type 1 and morbid type 2. So, morbid 1, we call it Wenkerback, and morbid 2, morbid 2, other one. Okay. So, morbid 1, other name is a Wenkerback. Okay. And the third degree, and we call it complete heart block, right? So, AV blocks, very important. Okay, let's go one by one. AV blocks, what you can see. In the first degree, AV block, the PR interval more than 200 millisecond, right? More than 200 millisecond. There's a no drop in of P waves, but the PR interval more than 200 millisecond. PR interval remain constant. Every P wave followed QRS, right? Here, first degree AV block long PR interval, right? The long PR interval here, right? Long PR interval. So morbid's 1, the type 2 one here, the type 2, so the second degree type 1, the morbid's 1 of Wenkerback. How it present? Progressive PR prolongation. So, okay. Um, so what is happening here? What is happening here? There's a drop present, right? Okay. First see. Okay, here P QRS, here T. P again this QRST complex. Then again P, and here it should be QRST complex, but it's absent, right? It's absent. So what is the basically happening in here, doctors? What is basically happening? Okay, here's the heart. Heart is present, SA node, AV node. So SA node is giving signals that stimulate the atrium. So atrium stimulate mean we can see the P waves. Then AV node get the signals and stimulate. Then it should be transfer this signal throughout the ventricles to the Purkinje fibers. But if there is okay, if there is a block in here, that means you can't pass signal here. You can't pass signal to these ventricles, right? If the ventricles are not depolarization, there's a no QRS, right? And no QRS, and there's a no ventricle repolarization as T also absent. So those everything is absent here. Here there's a block. So P wave is generating. Why? Because the atrium is okay. Here the atrium is okay, but there is a block. The sudden block is happened. So there's a no QRST. No QRST here. And again the next wave came. The next P wave came, and again it's beat, right? So the block happened. Then it's normal, like that. This is the way it happening, right? Here's the block, right, doctors? So I hope you get the idea. So block should be here. Block is here because this is the last. Okay, so here we call this drop. We call this drop, right? We call this drop because of the block. Okay. So drop is here. So progressive PR prolongation. So what does that mean? right? The PR. Here the PR is getting here increase in here. Okay, here as example progressively long as example here we can't. Okay, can you see that this length and this length? Which length is the high? This is A and this is B. Which is the highest length you can see? B, right? So as example, okay, just a idea. Okay, here you think it as a 1 centimeter, 1 centimeter. Here it's a 2 centimeter. It's length in, and here the drop is present. The PR intervals getting longer, then drop happen. As example, this is 1 centimeter, this is 2 centimeter, this is 3 centimeter, then drop happen, right? So that's what we call the length in of PR interval, right? Length in of PR interval, right? So we can see it in the Mobitz one of Venkaback, right? Venkaback, you can clearly see right here. The area is little than this area, right? Here you can see the very little, right? Here increase, here again increase more than this one, here then drop happen, right? Till the drop, the PR is increasing. So Mobitz 2, PR interval generally constant here. That means here also second degree, the same thing. AV block, the QRST is dropping here. But here the P waves before the PR length before the drops, all are equal. Here, can you see all are equal? There's a no difference, right? There's a no lengthing. Each PR is equal till the drop, right? Here, that's what we call PR interval generally constant. The sudden non-conducted P wave dropped QRS then may have 2 to 1 or higher grade conduction, right? We all know what does mean the 2 to 1. Then we have the complete heart block. This is from e-medicine. This is a e-medicine picture. So complete heart block. What you can see in the complete heart block. So it's like they are like the divorced couple. Divorced couple, okay? So the wife is doing whatever she wants. Okay, think the P as a wife, the QR is as the husband here. They are like there's a no relationship. They are divorced, right? Earlier the patient is okay, then they have the relationship between these PQRST, but here now they don't have any relationship. The wife is doing whatever she want, the husband is doing whatever he want, right? So because of that, their conduction system is very different. The atriums are conducting in their own rhythm and the ventricles are conducting on their own rhythm, right? They're contracting in their own way. That's what we have uh, that's why we don't have the relationship between them. So atrium and ventricle rhythms are independent, right? They are divorced. So ventricles rate usually slow, QRS may be narrow or broad depending on the scale focus. So, and other than that, what you can see in here? What you can see in here, doctors? So, how you should understand? Mm, okay, third degree, it's over, right? It's over, doctors. Divorced, right? Okay, what you can see between these P waves and these R waves? What you can see? Is there any connection? Can you see? Can you see, doctors? Can you see? Is there any relation between PP and RR? Yeah. No relationship between P and QRS by asking about PP intervals and RR intervals. So P and P intervals usually they have their own regular rhythm, right? The PP intervals. Can you see the PP intervals? So usually they have their own rhythm. Right here, the length. Can you check the length? Right, kind of same, right? But here, okay. This is, yeah, here, again here. Can you see they are having their own kind of regular rhythm, right? So our intervals, can you see they also have kind of same rhythm, right here? But they don't have the P and QRS don't have any relationship, okay? So remember these things, very important. Okay, I hope you get the idea. This is the one they have given in e-medicine. Will do. Okay, let's discuss about bundle branch blocks. Bundle branch blocks. What do you know about bundle branch blocks? What do you know about bundle branch block? So do you know about the William and Marrow? William and Marrow? William and Marrow doctors? What do you know about William and Marrow? Okay, just we'll start from William and Marrow, then we'll discuss. Okay, what is William and what is Marrow? So the word William, W, L, and M. That is very important. So L mean left bundle branch block, right? So okay, once you are thinking about bundle branch block, think about V1 and V6. V1 and V6. Then think about William and Marrow, right? Okay, here in the William we have L, that mean the left bundle branch block, and in the V1 we can see not the exact W wave, okay, not the exact W wave. Usually, can you see like here? This kind of W. So William in the V6 you can see like this kind of presentation. So that's what we called William and Marrow, right? I will show, okay? I will show there's another better picture that given in the life in the fast lane. Here, can you see V1, the W, right? Here, can you see the W, but not the proper W. This is the way that we used to remember. Here, can you see V6, kind of M kind of appearance, right? M kind of appearance, right, doctors? Here, we can see the dominant S wave and V6 broad notch M-shaped R wave, the notched M-shaped R wave, right? This is the left bundle branch block, right? Left bundle branch block. Okay, so in the right bundle branch block, what you can see, the right bundle branch block, remember it as a marrow. R, right? R mean the right bundle branch block. Then the starting with M. So that mean V1 you can see the M kind of presentation. M you can see in V1 and V6 you can see the W, right? V you can see the W. That's the remember, your starting letter is the V1, the last letter is the V6, right? Okay, here. Here the right bundle branch block, not very clear, but you can think like that way. Here, can you see? M kind of appearance, right? M kind of appearance here, right? In B1 and B6, the not the proper W, this like W, right? There is an easy way to remember, okay, but not all the time we can see this M and W, okay, but remember like this. So let's discuss about the general. So bundle branch block, what we have. We have the QRS. QRS is more than 120 millisecond. That means the broad complex we have, right? Broad complex we have right here. In the right bundle branch block, we have what? We have what, Dr. RSRR pattern. RSRR pattern, right? RSR pattern, right, doctor? So that's why we call it as M, right? So the yeah, that is the thing. Okay, what about the here the left bundle branch block? Here also the broad complex, right? Broad complex QRS, so more than 120 millisecond here. Broad notch R wave in 1 AVL V5. You should remember it as V6, right? V6, and here you can V1, you can see the W1, right? Predominantly negative QRS like a W letter. W letter. So just remember like this way. Here, the left bundle, deepest wave, that means remember it as a W letter. And here the notched QRS complex here R wave, it has the M, right? Okay, so that is the simplest way you can remember it, right? Okay, so let's discuss about MI. What do you know about acute coronary syndrome? Acute coronary syndrome. So we are starting like okay, that is even though we are having the sudden chest pain and those things, this is starting like that this way. Okay, onset and for several hours, right? So what you can see, the peak T waves, right? ST segments start to elevate, right? ST segments start to elevate, right? R wave normal or nearly normal in here, the onset and first several hours. So in the first day, you can clearly say ST elevation, very, very clearly marked as T elevation. You can see our amplitude is diminishing here because of the ST, the segment is elevating, right? That's the reason. Then first and second days here, the T wave inversion can be beginning and the ST elevation may can decrease, right? R wave gone or nearly gone, and you can see that significant pathological Q wave, right? Pathological Q wave. Hi, doctors. Then after 2 to 3 days, you can see the pathological Q wave, then deep T wave inversion. ST may be at the baseline. Then after several weeks, then there can be ST elevation may persistent. If aneurysm more develop like the complications, some R waves may be returned normal. Significant Q wave usually persistent. T wave often less inverted. Just remember, like this is the way it happening, but I have attached it for like to give a idea. But basically, remember we have STEMI, right? STEMI in the STEMI, uh, sorry, that means ST elevated acute coronary syndrome. You can see ST elevation because we have non-STEMI acute coronary syndrome as well. Okay, I will explain that part as well. You can see the ST elevations, then the Q waves has improved like this, the way like usually they are happening in according to this way. Okay, so here what you can see, these are the some examples in here. The example one, what you can see, doctors, ST segment elevations here you can see, right? And the pathological Q, not very prominent pathological Q. ST segment depression here you can see. ST segment depression here, the elevations and the pink color pathological Q. Okay, then other thing is according to their locations, right? I told you inferior, right ventricular, the septal, those things. Okay, here again, if it is a lateral, you can see elevation, the same thing. One AVL, V5, V6, inferior. Second, sorry, um, it's one tree and AVF, right? So anterior septal V1 to V4, extensive anterior V1 to V6. In the posterior walls, we can look for the V1 to V3, but to confirm, we have to check for the other leads, V7 to V9, right? V7 to V9 in the posterior leads, right? Okay, so yeah, and if it is a right ventricular inferior leads with V4, just forget it. Like don't need to remember everything. But basically, lateral, inferior, anterior, septal, and the posterior also you can remember like that way. Okay, the very important thing. Very important. Okay, then we'll discuss about non-ST elevated MI, non-ST elevated acute coronary syndrome, because basically we are dividing into ACS, right? ACS we are dividing into what? ST elevated acute coronary syndrome and non-ST elevated acute coronary syndrome. Again, non-ST elevated acute coronary syndrome, we are again divided into two things, right? So one is non-STEMI, other one is unstable angina. Right, unstable angina. I hope you remember these things. So here, non-ST elevation acute coronary syndrome encompass into two main entitles, non-ST elevated MI and unstable angina. So how to differentiate non-STEMI from the unstable angina, doctors? So what is the key difference to differentiate those two things? Tell me, doctors. Tell me. From what? Yes, according to the cardiac enzymes, right here, the difference between these two conditions usually retrospective based on the presence or absence of the rest cardiac enzyme, the troponin mainly at 8 to 12 hours after the onset of chest pain. So usually there's a no the troponin elevation in unstable angina. That's the only thing we can use to differentiate. Okay. In here, the two main ECG pattern with non-ST elevated acute coronary syndrome. So what are those things? You have ST segment depressions and T wave flattering or inversion, right? Doctor, so T segment depression and T wave inversion mainly you can see, right? So here. The ST depression, it can be unslope in ST depression. It can be downslope in here, unsloping, the downsloping, and there can be horizontal ST depression, right? So this is the way. And here the remember the ST depression can be those in the horizontal or downsloping ST depression more than or equal to 0.5 millimeter at the J point in more than two contiguous leads indicate the MI. So ST depression equal or more than 1 millimeter is more specific and convey worse prognosis. More than 2 millimeter in more than 3 leads associated with the high probability of non-STEMI and predict the significant mortality, right? So upslope in ST depression non-specific for MI, right? So very important these things. And yeah, you can see the ST depression right here. Here you can see the ST depression. Okay, so the T inversion. T inversion may be considered be evidence of MI. At least 1 millimeter deep. 1 millimeter at least deep should be their presence in equal or more than two contiguous leads that have the dominant RA and R to S ratio more than 1 should be the dynamic not present on all ECG or changing over the time. So here, mm, yeah, you can see the T wave inversion. T wave inversion. Okay. So, okay, let's discuss about the other cases like pericarditis. How this pericarditis present, doctors? Pericarditis. Okay, pericarditis ECG. According to the stage, that ECG is different, right? It's stage one. Stage one. Here, the stage one widespread ST elevation and PR depression with reciprocal changes in AVR. Very important. Occurs in the first 2 weeks, right? Here, diffuse ST segment elevation. Can you see it's like a diffuse pattern here? You can see the diffuse pattern here. Can you see the diffuse pattern? Here, diffuse ST elevation. Here, you can see and PR segment depression. PR segment depression, you can see. The B is a reciprocal one. Usually B you can see in AVR and occasionally in V1. The remember, okay? Once you see the pericarditis ECG, think about the reciprocal changes in AVR. Reciprocal mean the mirror effect, right? Can you see it's like a mirror effect in here, right? The same thing mirror effect in. This is this is having what? This is having the upright and this is downright because of the reciprocal, right? That means mirror changing. So stage two, normalization of ST segment and PR segment. Here, can you see it's kind of normalization. Then widespread T wave inversion. Here, widespread T wave inversion in stage three, stage four normalization. Stage three pattern T wave become inverted. Here, 3 to several weeks, right? 3 weeks to several weeks, and the stage two normalization of ST change, generalized T wave flattening 1 to 3 weeks. So initially, this is diffuse ST and reciprocal changes in first 2 weeks, right? Then after 1 to 3 weeks, there can be normalization of ST and T wave can be flat, right? Flat. So then flat T wave become inverted third week to the several weeks and the ECG return normal after several weeks in the last stage, right? This is the things that you need to understand because pericarditis topics they are usually asking, right? So very important. Okay, here the same thing, okay. Same thing. And here you can see the widespread concave ST elevations and PR depression present through the precordial V2 to V6 and lymph nodes 1 to ABL. Okay, right? The reciprocal ST depression and PR elevation in AVR. So yeah, AVR, yeah, reciprocal changes, right? Reciprocal changes. Okay, so how we should differentiate STEMI ST elevation from pericarditis ST elevations? Very important. How do here the stem is having the regional ST elevations, and we have the diffuse or widespread ST elevation here, and here the PR depression, and here reciprocal change is often present, but here mainly you can see in AVR the reciprocal changes, right? So let's discuss about some abnormalities like electrolyte abnormalities like hyperkalemia. What are the features of hyperkalemia? ECG, hyperkalemia ECG, what are the things that you can see? Okay, tall T wave. What are the other things? Tall T wave. Other than that, PR prolongation, right? Okay, here. And so remember the push and pull effect for the hyperkalemia and hypokalemia. So if it is a hyperkalemia, you are pulling it, right? Peak T wave, P wave flattening, PR prolongation, but Hubert is complex. So you are pulling the T wave. That's why you can see the peaked or tall T wave. If it is hypokalemia, you are pushing the T wave. Because of that, T wave is going down. That means T wave inversion with ST depression and prominent U wave. Can you see? Because you are pushing this. You are pushing T wave. Because of that, there can be another wave we call the prominent Q wave. Q wave is appearing, right? Yeah, I hope this picture is a very good picture. Then you can remember these things. Okay. Okay, here according to the potassium level, if it is 5.5 to 6.5, there can be peak T waves. 6.5 to 7, P wave, widening, flattening, PR prolongation. Here, P wave eventually disappear. 7 to 9, there is a conduct abnormalities can be associated with the bradyarrhythmias, right? If it is more than 9, it's like a very severe case, right? So usually if it is 9, you can see the sinus wave, right? Sinus wave appearance. So yeah, ventricular fibrillations and asystole is very severe case if it is more than 9. Okay, more than 9. So hyperkalemia, you can see the flat T wave and the prominent U wave. The same thing here, the T wave. T wave is going down. Because of this effect, there can be a formation of U wave. You can see in hypokalemia, right? Less than 2.7 here. Yeah, QU interval. And other than that, what you can see, prominent U wave, prolonged PR interval, increased P wave amplitude. Okay, apparent long QT interval due to the fusion of T and U wave, right? Long QU interval. Long QU interval, right? Here, widespread state depression and T wave inversion. Okay, here you can see the U wave, T wave inversion. Long QU interval as well here. Very good. T wave, sorry, U wave you can see. Yeah. The T wave inversion, then U wave like that. So hypercalcemia. How hypercalcemia present, doctors? How hypocalcemia present? Hypo. Okay. Hypocalcemia cause QT prolongation primarily by prolonging the T segment, right? Prolonged QT you can see why due to mainly due to the prolonged ST segment, right? So here the T waves typically left unchanged. Dysarrhythmias are common, although atrial fibrillation has been reported. Torsade depointers may occur, but much less common than hyperkalemia or hypomagnesemia. Here hypocalcemia case, QT 500 millisecond in patient with hypoparathyroidism, post thyroidectomy, and serum corrected calcium 1.4, right? 1 point. Okay, it's a typical presentation. Next, hypercalcemia. Hypercalcemia is a hypocalcemia. Prolonged QT, that means the opposite side here, the short QT, mainly due to short ST segment, right? Here the main ECG abnormality is shortening of QT intervals. Here you can see hypercalcemia, and this is a normal one. Hypokalemia, right? Hypokalemia here. QT. Hypokalemia long QT, hyperkalemia short QT, right? Short QT. Ventricular irritability and VF arrest has been reported with extreme hyperkalemia, right? And what are the other things? See, other than that, in severe hypercalcemia, Osborne wave or J wave may be seen. So, what is this J wave? Can you see? There's like a notch kind of thing, the J waves. So, in severe case, you can see these Osborne waves or the J waves like this in hypercalcemia, right? Okay. So other things are pre-excitation cases. So how the Wolf Parkinson White syndrome present? Wolf Parkinson White syndrome. Doctors, like you're understanding everything, right? I'm just quickly explaining. Is this too fast or do you need? Is it everything okay, right? Is and everything understandable, right? If you have any doubt, just ask me, okay? Because I'm just quickly doing it because then we can discuss a lot of emergency questions because that is the practice we just need, right? So pre-excitation things, Wolf Parkinson White syndrome. So we have tried short PR less than 120 millisecond, delta waves and broad QRS, right? What is delta wave? That is slurred initial upstroke of QRS, right? Associated with the re-entry tachyarrhythmia here. So here. Okay, so where's the delta wave? Where's the delta wave? Delta wave here. Okay, delta wave is what? Delta wave is like here, it's like a quick upstroke of here. Can you see? This is the delta wave here. Can you see the delta wave here? The delta wave here, delta wave here is a delta wave, right? This is the delta wave, the typical presentation of delta wave, right? So, yeah. And here what we have delta wave, PR interval less than 120 millisecond, QR is prolonged 100, more than 110 millisecond, by QR prolonged. So why here P Q, okay, this is the way that is, okay. So P Q R S T, right? So here it is happening like this kind of things. Because of that, you can see, right, the typically the QRS is widened, right? QRS is increased. Then PR interval is reducing, right? PR interval reducing because there's like some upstroke, right? Starting like this way. So because of that, the PR interval is reducing, right? PR interval is reducing like that. So like once you remember the how the delta wave present, you can think because of the delta wave, the other things can happen, right? Because of this delta wave, because it's widening, because of widening, there's a QRS prolongation, and because of this widening, the R is get reduced. Because of that, PR interval is getting reduced, right? This is the typical presentation with delta waves, right? Okay, so Wolf Parkinson. Easy. So the Brugada, what is the Brugada syndrome? I have not seen recently asking about the Brugada, but this Brugada is very important. Very important, the Brugada. What do you know about Brugada? Why Brugada very important? Brugada syndrome can cause dangerous ventricular arrhythmias and sudden cardiac death, right? That is why the Brugada is important. It's an inherited cardiac electrical disorder due to the channelopathy, right? Predisposed to VT or VF. And that can cause the cardiac arrest. Patient may present with the unexplained syncope, especially at the rest or during the sleep. May have family history of sudden cardiac death. Fever is important because it can unmarked or worsen the Brugada ECG pattern, right? Okay, here very important. We have the different types of Brugada. We have Brugada type 1, type 2, and type 3. I don't know you have idea about these three or not. But type 1 is the most important one. Okay, other types are you should know, but not very important. So what is the type 1? What you can see? You can see the covered ST elevation. Can you see? Quote ST segment elevation, right? It's like the shapes like this. Can you see? Can you see the ST elevation, the pattern of it? So that is very important. So this is the diagnosis. So this ST elevation is more than 2 millimeter, more than or equal 2 millimeter in the right precordial leads V1 to V2, followed by the negative T wave. Negative T wave. Here it is negative T wave here. Followed by the negative T wave. This is the diagnostic of Brugada ECG pattern. Okay, this is the type 1 what they have given. Okay, the same thing V1 to V3. Here V1 to V3. So you can see, right? Here you can see the pattern and negative T waves. This is the only ECG abnormality that is potentially diagnosed. That is the only thing that is potentially diagnosis, and we call it Brugada sign, right? Brugada sign. The ECG abnormality must be associated with the one of following clinical criteria to make the diagnosis: documented ventricular fibrillation or polymorphic ventricular tachyarrhythmia, family history of sudden cardiac death less than 45 years, this covered type ECG of family members, right? This pattern. Inducibility of VT with programmed electrical stimulation, syncope or nocturnal agonal respiration. So very important. So other than that, what is the type 2? You can see the saddleback ST elevation more than or equal to 2 millimeter, with ST segment remaining more than or equal 1 millimeter above baseline and positive biphasic T wave. Here the saddleback shape, right? Saddleback shape. What is saddleback? This is the saddleback shape, right? This is the saddleback shape. Right? This is the saddleback shape. Like that. Okay, but it is not diagnostic. Once you see this, that is suspicious. Okay, that is suspicious. The type 3, this saddleback appearance, those things, it's less than 1 millimeter, not diagnostic. Okay, not diagnostic. So remember, the type 1 is the mainly diagnostic one, right? Okay, I hope you get the longevity we have discussed. Okay, how left ventricular hypertrophy present? Left ventricular hypertrophy. What are the features, ECG criteria? And we have the diagnostic criteria, but you don't need to remember full diagnostic criteria here because we have this criteria, what we call this one. 1 minute. Okay, well, I can't remember the name, but there's a criteria called this one. Here, the gun. No, there's a criteria, but you don't need to remember. Just remember the basic things. In left ventricular hypertrophy, but you can see the increased QRS voltage, right? So voltage is depend on what? Voltage is depend on what, doctors? So how to check the voltage? How to check? It's shown by what? The QRS voltage. The height, right? Height of the QRS complex, right? Height is the one that we are checking the voltage, right? Right, doctors? So, and here other than that, what we can see is amplitude, right? Yeah. Okay, here, just simply remember the height. Measures on the vertical axis, right? So here, increase QRS voltage, deep S wave in V1, the tall R waves in V5 to V6, and the left axis deviation can be seen, right? Okay, so here, yeah. Okay, here this is the main one. They are telling the left ventricular hypertrophy produce the electrical phenotype may induce the increased QRS voltage, delayed ventricular activation, and secondary STT abnormalities. ECG criteria generally specific but insensitive. A positive result supports the left ventricular hypertrophy, while a negative ECG does not exclude the increased left ventricular mass. Right? Interpret voltage alongside the repolarization abnormalities, atrial find in QRS duration axis and the clinical contents, right? Like that. So here are the additional criteria. The atrial enlargement, left axis deviation, is elevation in the right precordial leads V1 to V3. The prominent U waves also can be seen. Okay, like that. Okay, 1 minute, doctors. I'll explain. Okay, here there's one picture. Let's see what they have given in here. I thought I have not attached it here. Markedly increase left ventricular voltage, huge precordial R and S wave that overlap with the adjacent lead. Mm, yeah, so here you can see the R is increased, right? Here R, the height is increased. That means the voltage is high, right? Can you see the higher voltage, right? The QRS complex. See the R wave peak time more than 50 millisecond in V5 to V6. So V5 to V6. So here you can see the highestly increase this one, right? Associated with the QRS board in, yeah. Okay, like these are the I will show it from in the image equations, right? With the question. Otherwise, it's not like just from the ECG. It's not because sometimes ECG not given the proper case, not conclusive, right? That mean like if there's a no ECG finding, that doesn't mean we can't exclude the hypertrophy, right? Okay, the right ventricular hypertrophy, right axis deviation, dominant tall R waves in B1, deep S wave in lateral leads, right ventricular strain may be caused, T wave inversion in the right precordial leads. Okay. So here they have given again the diagnostic criteria in life in the fast lane. Here the right axis deviation, dominant R wave in V1. Remember the V1, dominant S wave in V5 or V6. QRS duration less than 120 millisecond. Okay. There are no universally accepted criteria for diagnosing right ventricular hypertrophy in presence of right bundle branch block. The standard voltage criteria does not apply. However, the presence of incomplete complete RBP with the tall T wave in V1 with right axis deviation and the supporting criteria, we can consider RVH because they mostly it associated with the bundle branch block, right? Like that. Okay, here's the example. And the dominant R wave in V1. Yeah, V1, the dominant R wave, the dominant S wave in V6. There's a V6. Okay, the dominant S wave here. Yeah, you can see, right? More than 7 millimeter. Here, V1 also, more than, yes, where's V1? Here, V1, more than 7 millimeter. I told you, like, more than height is increased, means the voltage is high, right? Voltage is high. Okay. Yeah. Okay, so that is like keep the general idea like that. So let's discuss about some diseases. How the pulmonary embolism present? How pulmonary embolism present? What are the features pulmonary embolism? Tell me, doctors. Okay, I forget to tell you how to understand the deviation. The according to the according to the first and third lead, according to this hypertrophy. Okay, like right axis deviation, how to understand? Check lead 1 and lead 3. Tell me, doctors, is there any simple way you can understand? Easy, I will tell you easiest way because I forgot to tell. So right axis deviation. Okay, here what you can see in the lead one what you can see. This is what you can see. One. The right axis deviation. You can see in the lead one, the negative, right? QRS negative, and here lead 3, QRS is positive. That means here they are trying to they are going to meet, right? Think this way. They are going to meet. Can you see? They are going to meet, right? They are think the right axis deviation as lovers. They are going to meet the like thing, boyfriend and girlfriend and boyfriend. They are going to meet, right? Okay, this is for the right axis deviation. Think that way. Okay, then left axis deviation. What you can see? Left axis deviation. Left axis deviation. Okay, here. Okay, they're going to break up, right? He's going this side and she's going this side, right? This is the simplest way you can remember. I know this is weird, but it's easy to remember, right? Always check lead 1 and lead 3. Then you can decide if you have any doubt. This is not the proper standard way. Okay, this is the simplest way I used to remember. Okay, I used to remember. Here's a positive, here's a negative. So here he's going this side and she's going this side. Okay, the simplest way. Yes, coming towards and looking, going away. Okay, so pulmonary embolism. Pulmonary embolism, what you? So most common ECG abnormality is sinus tachycardia. That is given in as a image question as well. Okay, that is given as a emergency question. What is the most common abnormality given a P scenario? And most of doctors, uh, they have chosen when we were doing the pulmonary embolism, this S1 QT, Q3, T3, but that is not the most common. Most common one is the sinus tachycardia. But this is a specific one, but rarely present, right? Not all the cases present. Rarely we can find this S1 Q3 T3 pattern. Okay. So other than that, you can see the right axis deviation, right bundle branch block, right ventricular strain, T wave inversion in V1 to V3, S1 Q3 T3 pattern. You can see that what is it? S1 deep S in lead 1. Q waves in lead 3, T waves inversion in lead 3, right? So that's what we call it, this S1 Q3 T3 pattern. You can remember S1 QT3. So take the tree out and remember S, you can remember, right? SQT 3. So no need to remember 1. So remember these 3 common 4. Or otherwise you can remember S3 QT. So trace common for Q and T, S3 QT. Like that. Anyway, it's easier for you, okay? But don't think S3 is taken out from Q and T, okay? Like that way. Okay, I have not attached here the pattern, sorry. Okay, here. Same thing, okay, here. Here you can see the right bundle branch block as well. Here you can see M, right? Here M, the notched one M, the marrow, right? And V6 kind of W presentation, you can see right bundle branch block. And here S1, okay, S1, deep S, Q3 and T3 pattern. Okay, 3, here's the T, 3, Q and okay, inverted T also present. Here you can see the pattern and T wave inversion in V1 to 4. Okay, V1 to V4. Yeah, you can see the here the T wave inversion as well. Okay, good. Then the clockwise rotation is persistent S wave in V6. The clockwise rotation of persistent S wave in V6. as the X wave clockwise rotation. So here, okay, here you can see S wave, but I can't like I don't know how to explain about the clockwise rotation, but that is not very specific. The mainly remember these things. Okay, these are the main things: right axis deviation, right bundle branch block, right ventricular strain, the T inversion V1 to V4, and this deep S in one, the Q wave in lead 3, and the T wave inversion in lead 3. Those things are very important. These things. Okay, let's tell me about the in Hocum. What you can see earlier, we call it. Hokum, but now we call it hypertrophic cardiomyopathy. But still, we are using this Hokum word. Okay. In the emergency also we can see they have used Hokum. So what you can see, it's very important. Left ventricular hypertrophy pattern you can see. And other than that, you have deep narrow Q wave pattern. Deep narrow, the dagger like Q wave. Now you should have the problem how to differentiate this pattern, this narrow, the dagger like Q wave from the MI Q wave, because MI also having the pathological Q wave. So how to differentiate, doctors? Yeah, first we'll differentiate that. Here, Q wave seen in the Hocum is a mimic prior to MI, although the Q wave morphology is different. Infarction Q wave are typically more than 40 millisecond duration, but septal Q waves in the Hocum are less than 40 millisecond, right? And the lateral Q waves are more common than in inferior Q waves in Hocum, right? Remember the 40 millisecond duration, that is very important. Okay, so let's see what you can see. Can you see the narrow, the dagger-like skew wave? Inferior, let's 2, 3, and AVF, right? 2, 3, and AV. Here, can you see the dagger-like, the narrow Q wave, narrowed the dagger-like Q waves here, right? So, yeah, that is the most important thing other than the left ventricular hypertrophy, as we discussed earlier, we can see, right? So these are the things, and here, yeah. Another thing, if it is a apical Hocum, apical hypertrophic cardiomyopathy, but you can see the giant T wave inversion. The apical one is giant T wave inversion. Here you can see the giant T wave inversion, right? Giant T wave inversion, but if it is in only apical hypertrophic cardiomyopathy, but it's very uncommon, right? So how you can see the digoxin effect. Okay, here, doctors, the thing is, I hope everyone know digoxin, like we have digoxin effect and toxicity. How to differentiate digoxin effect and toxicity? So, what is digoxin effect? What is digoxin effect, doctors? What is digoxin effect? Tell me. Why we have something digoxin effect and toxicity? Digoxin effect means what? The patients who are taking digoxin in their therapeutic level as their medication, they can have this digoxin effect. Digoxin effect, is it toxicity? In digoxin effect means is there a toxicity present or not? Patient who are having the therapeutic dose, they can have this digoxin effect. Digoxin effect mean they don't have any toxicity or anything. Okay, that doesn't mean any toxicity. That just because they are taking this digoxin as a drug, for that there can be some ECG effect. So what is those ECG effect? Then in that case you can see the down slope in ST depression, right? Yes, the reverse tick sign, right? Reverse tick sign. Okay, here this is the digoxin effect, the reverse tick sign, right? Reverse stick sign, or we call it hockey stick sign. Okay, the or Salvador Daily mustache sign, right? So that doesn't mean there's a toxicity. Remember, don't confuse the therapeutic effect. Don't confuse the decoxic effect from the toxicity, right? And here you can see the this ST, this downslope in ST depression or reverse dip sign with the short QT, and PR prolongation may be occur, and T wave changes also you can see. But in here, digoxin toxicity, that means there is a overdose, right? There is a overdose in digoxin toxicity, right, doctors? So it can be associated with what? The features? What are the features that can be associated with digoxin toxicity? That is excessive digoxin, right? Excessive digoxin, that mean the overdose, right? Not in therapeutic dose. And there, because if there's a digoxin toxicity, there can be what? Excess dose, or sometimes some patients, especially like taking the therapeutic dose also, they can be toxic, right? Or there can be due to dehydration or hypokalemia or some kind of drugs, right? The features are, you can see the GI doctors, can you wait? Because there's no one in my home. Oh, okay, someone picks. Because the land phone line is ringing and no one is picking up. Okay, again calling. Give me 1 minute, I will come back because there's no one to pick. Sorry for that, doctors. Yeah. Okay, so that means the patient is associated with what? Sorry, nausea, vomiting, right? Abdominal discomfort, right? So fatigue, weakness, those things can be present, right? So here, what are the other features that can associated in here? Associated in the digoxin toxicity, there can be AV blocks, right? Especially the AV block that they have asked some question in June, right? I think they have given the patient who are taking digoxin with some AV blocks, right? AV blocks and the bradycardia. Hi, doctors. So usually atrial tachycardia with AV blocks, those are the things that they can see. Right? They can see. And here also you can see the digox in the typical effect, because usually the patient, there can be a normal therapeutic dose taking patient. They already have this reverse tick sign and there's overdose. And other than this, there can be the AV blocks, the ventricular ectopes, those can be seen, right? Okay, I think. Mhm. Yeah, biphasic T wave. Okay, here the T wave changes. The most common T wave abnormality is biphasic T wave with the initial negative deflection and the terminal positive deflection. So deflection. This is usually seen in lead with the dominant R wave. The first part of the T wave is typically continuous. Okay, first part of the T wave is typically continuous with the depressed ST segment. Here, the depressed ST segment, the terminal positive deflection may be peaked or have prominent U wave superimposed upon it. Okay. Yeah. Just remember those things: toxicity, bradyarrhythmia, AV block, atrial tachycardia with blocked ventricular ectopy, ventricular arrhythmia. Those things you can see in the toxicity. So don't confuse toxicity and the digoxin effect, right? I hope everything is understandable, doctor. Is everything understandable? Is everything understandable about these are the like main ECG things that you should remember. I hope everything is clear and everything has revised, because we have done a small revision. So we'll take a 10 minutes break and we'll do some ECG from e-medicine. Okay, e-medicine, try to understand the main things. Let's take a break. Okay, 10 minutes, 5:03, 5:30. 5:13 will start. Okay, do you want to discuss the emergency or like discuss the treatment? What do you think? What do you want actually? Because it seems like a very little amount of doctors are here. Okay, okay, we'll do, right? Okay. I don't think I can discuss everything, but I'll will do some at least 10 to 12 questions, right? Then it will be helpful. Okay, here. 76-year-old woman present to the ED with shortness of breath has progressively worsened of worst over past 2 days. She does not have cough, hemoptysis, or chest pain. She has a medical history of stage 4 breast cancer on palliative chemotherapy and chronic kidney disease with GFR 46. Her medication include letrozole, paracetamol as required. She has 42 pack years smoking history and there's a no recent travel history. On examination, she appears well. Her pulse rate is 110, regular BP 134 by 90, respiratory rate 22, SpO2 94%, and the temperature 36.9. Erythema on her right leg and which tender on palpation or auscultation of lung revealed the bronchovesicular breath sound with no adventitious sound on her ECG. So, which one of the following most appropriate diagnostic investigation? Okay, so what do you think? What is this, doctors? What do you think? What is this, doctors? Okay, so what do you think? What is the answer? It's a pulmonary embolism case. Can you see they have given what you can see in here? Okay, what is the answer? Quickly, quickly answer. You don't have much time. Quickly answer, doctors. We're all going with CTPA. Let's check. Yes, you are correct, right? You are correct. This is what? Here, most likely the pulmonary embolism, right? Pulmonary embolism. And here you all know the and here the ECG demonstrates the sinus tachycardia, most common ECG pattern in the pulmonary embolism. Wholly non-specific. Okay, here's a sinus tachycardia, but it is non-specific, right? Non-specific. But here the presentation they have given with the pulmonary embolism will do like mainly the ECG things only. Okay, ambulance force by 1 minute, doctor. I want to do the SVTs things. Okay. Okay, we'll do this one. A 34-year-old Aboriginal man presented to the ED with 2-day history of central chest pain. First noticed shortly after arriving the Adelaide. Following 8-hour drive from the Sesuda, the pain is sharp made worse by cough. In the report, it's worse when lying flat and is when he leaned forward. He has had mild fever and general malaise over the past few days and his medical history type 2 diabetes and the obesity. The patient is appears uncomfortable. Sorry, appears comfortable. Pulse 85, BP 125 by 75, respirator 16 here. Heart sounds are dual with no murmur. Chest is clear to auscultation. Calves are soft and untamed. ECG performed. What you can see. Here, what you can see, doctor. Central chest pain. 8 hours drive from Sistuda. What you can see here. Okay, let's check your answer. Yeah, what you can see, diffuse T elevation, right? Diffuse T elevation. Here the patients, the chest pain worse when lying flat and improve when leaning forward. This is a very important. This is a classical finding of the pericarditis, right? Accompanied with the low grade fever and malaise. ECG shows the global ST elevation with PR different. Global ST elevation means the same, the diffuse ST elevations and the PR depression. Okay, so this is the clinical presentation of pericarditis. Okay, yeah, let's see. Mm, okay, maybe will I want to ask the main questions from SVT, those things. Okay, I think better we'll do like this. the topic wise, otherwise we will miss like the most important thing, because I want to go by this, because these topics they have asked, I think ventricular fibrillation they have asked in June, right, doctors? June they have asked in. 1 minute. Okay, so I will explain like this. Okay, 66-year-old man being monitored by ICU. Yeah, I see. Sorry, ICU following a coronary artery bypass surgery. He has medical history of ischemic heart disease, hypercholesterolemia, hypertension, type 2 diabetes. Medication include aspirin, atorvastatin, amlodipine, and metformin. During the nursing handover, he suddenly lost the consciousness. The cardiac monitor tracing is shown below, and here the radial artery. Atrial line shows the no pulsatile activity. The emergency buzzer is pressed. Resuscitation team arrive immediately with defibrillator. Which one of the following is most appropriate first step in management? Now tell me. Tell me, doctor. This is very important. I want to explain. Tell me. What about the doctors? 1 minute. Okay. Mm-hmm. Here. Okay. Here, why not just compression? Why not just compression, doctors? Tell me. Why not just compression? Tell me, doctors. Tell me. Because this is the most important. Mhm. Here, the scene is what? Weakness, ventricular fibrillation, right? Ventricular fibrillation has weakness, and there is a defibrillator available at the moment, right? Immediately available. And here, what they have, and here in the monitor, what you can see. Monitor, you can see ventricular fibrillation, and this is a shockable rhythm, right? Shockable rhythm. Then what you can do, you have to start the defibrillation, right? Immediate defibrillation, right? Right, doctors here. The immediate defibrillation attempt is correct management for weakness ventricular fibrillation arrest in the monitored setting. This approach different from the weakness arrest or arrest is unmonitored setting, right? So rationale is the early defibrillation is the most effective intervention for the ventricular fibrillation, and in the monitored setting there are minimal delay between arrest and shock delivery. The use of three stacked shock for further emphasized by the Australian Resuscitation Council for VF arrest post cardiac surgery. Okay, here up three stacks of shocks should be considered in a cardiac arrest in the shockable rhythm when the arrest is witnessed and monitored. The defibrillator is immediately available. The time required for rhythm recognition for recharging defibrillator is short, like less than 10 seconds. So if you are not very familiar with this topic, doctor, this part, please, if it is a weakness ventricular fibrillation or immediately it is defibrillator available, we are just starting the is shockable the shock, right? Shock, because like otherwise there can be, you can be think about the why not chest compression. It be appropriate in unwitnessed arrest or after three unsuccessful shock. However, in witness VF with immediate defibrillator availability, shocking take the priority over the compression, right? If please take a screenshot because we have discussed in our June recalls as well. This is very important. Okay, very important. That's why I want to start with that because I know this can be this can be quick. This can be this can be given in mostly in August as well, because the recalls topics are repeating right here. Next one, 50-year-old woman brought to the emergency department following a witness collapse. Witness collapse. She has no significant medical history and take no regular medication. So on examination, she is unconscious and pulseless. Cardiopulmonary resuscitation is in progress and defibrillator is attached. The following four rhythm strips are displayed on the defibrillator at the rhythm check in the first four cycles of cardiopulmonary resuscitation. This is the 1, 2, 3, 4 images. So here, which one of the following is appropriate sequence of the defibrillation for these four rhythm check? Tell me, doctors. Quickly answer. So in that case, you need to know what are the shockable rhythms and what are the non-shockable rhythms, right? What are the non-shockable rhythms? Doctors, quickly answer. Yeah, here why? The first strip shows the ventricular fibrillation. Yeah, you can see the ventricular fibrillation, right? So it's a shockable rhythm. The second picture. Second, the second strip show the organized electrical activity without pulse. So here, here what we call it? In the second strip, it's a PEA, right? Here, PEA mean what? Here they have, right? They have electrical activity but no pulse. But because of that, it's not a shockable rhythm, right? So no shock. The third strip show the ventricular tachycardia. Anyway, VT is a shockable rhythm, right? Shockable rhythm. So you have to give shock. The fourth strip. So fourth strip is the asystole, which is non-shockable, right? So very important. Okay, I'll show there's one more question. Okay, here. 65 men present to the AD ambulance with 30 minutes history of crushing central chest pain. Sorry, doctors. Crushing central chest pain. Yeah, palpitations and sweating has no significant medical history, no regular medication. During transfer ambulance due to resuscitation may he became unresponsive, he is collapsed, airway patent, but he is breathing infrequently, grasp breathing. Regularly, yeah, here gasping motion. His pulse is not palpable. The trachea on the ambulance monitor, not capable of defibrillation, shows as below. So in this case, what you need to give? In this case, what you need to give? In here, yes. In here, the most important thing is chest compressions, right? Here, the patient has suffered a cardiac arrest with the ventricular fibrillation, the pulseless arrest rhythm, likely due to the acute MI. The patient is exhibiting the agonal breathing, the grasping, right, which should be not mistaken for normal effective breathing. And in any patient who is unresponsive and not breathing normally, chest compression should be the initial after confirming the cardiac arrest, right? Initial after confirming the early chest compression are the most important initial treatment in the cardiac arrest, right? So what you need to immediate management is what doctors immediate management for the shockable rhythm. So you have to okay if it is like as an example if you have seen a patient in some cafe or like in a shopping mall somewhere unresponsive, right? You have to what call for help, right? Call for help, right, doctors? So in and that you have to check for this ABC, and then after you are thinking pulse and everything, you're thinking it as a cardiac collapse. You have to start immediately. You have to start the high quality CPR, not just CPR, high quality CPR, right? That is has the main important things to save their life, right? So you have to start it then Then after because you are calling the help after they are available, in that case you can think about the DC, giving DC shock, right? Giving DC shocks and like that. I'm just explaining like the very basic thing. But if you are witnessing this one, the patient is attached into the monitor or patient in ICU and the defibrillator immediately available, in that case you have to go with immediately defibrillator, right? Defibrillator, that is very important here. Also, defibrillation differs from the cardio version is that not synchronized to QRS complexes and is used for pulse rest rhythm. Okay, that is something different they have mentioned in here. And the cardio version, that is two different things, right? Okay, so then, okay, will ventricular tachycardia. Now tell me the management of ventricular tachycardia, doctors. Ventricular tachycardia. Okay, here, let's do 50-year-old man present to the 80 with palpitations. 2 hours ago, he was discharged from the endoscopy suite following elective endoscopic retrograde cholangiography for removal of the gallstone from the bile duct. The procedure was uncompleted. He has no significant medical history, no regular medications, denies chest pain or shortness of breath. On examination, he appears comfortable. His pulse rate is 140, blood pressure 110 by 68. The respiratory rate is 16, SpO2 98. The temperature 36.8, GCS 15. Here ECG is here. And here his vitals remain unchanged over 30 minutes of the observation. Which one of the following is most appropriate initial management? Now tell me, doctors. Quickly. What about the doctors? Doctors, please quickly answer. So what is this? This is a VT, right? Okay, this is a VT, right? Here, the patient is having but hemodynamically stable monomorphic ventricular tachycardia. The management approach depends on the hemodynamic stability, right? Intravenous amiodarone is the first line agent for the chemical cardioversion in stable VT. A broad spectrum class 3 antiarrhythmic amiodarone prolong the repolarization, decrease the excitability, and suppress the re-entrant circuit, making the most effective option for the terminating monomorphic VT. So loading dose is 300 milligrams IV over 1 hour. The maintenance infusion 900 milligrams IV over 24 hours, right? So when we should go with the electrical cardioversion if the patient is hemodynamically unstable, right? Okay, I'll show quickly. Okay, the management quickly. Okay, here. So here, what are the okay? So if it is a okay, first tell me if it is a non-stain VT, what we can give non-stain VT. If it is a non-stain VT, what we can give non-sustain VT. Okay, that is also very important. If it is a non-sustained VT, that means less than 30 seconds, right? Less than 30 seconds. So first line is beta blockers. Okay, don't confuse these things with the sustained VT. Okay, so beta blockers first we have give. So if it is sustained VT, sustainability. First, we have to understand the patient is stable or unstable. If it is unstable VT, you have to go with immediate DC cardioversion. If it is stable VT, you have to use antiarrhythmic drugs, right? You are starting with IV amiodarone, right? 300 milligrams over 30 minutes, then 900 milligrams over 24 hours, right? Or you have IV lidocaine if appropriate, right? Cardioversion if drugs are failed here. Here they have given in the TG amiodarone as the first choice and the lidocaine as the second choice, right? Okay. Then you have the long-term management for sustained VT with structural heart disease. In that case, you have to assess for the coronary disease and LV dysfunction. Early electrophysiological referral, ICD is preferred as it reduces the mortality, right? For structural problems, right? Long-term management. And the long-term management, sustained VT without structural problem, ICD not usually needed, right? Especially required needed, but no need ICD, because here we are using ICD because of the structural heart diseases, right? Here you can use the symptom control with beta blockers, flecainide, or verapamil, catheter ablation if episodes are frequent, the recurrent cases. Okay, so those are the things that you need to understand. Okay, patient sudden level of VT and the patient's blood pressure is 85 by 50. In that case, patient is unstable. In that case, what we can do here, we have to go with synchronized cardioversion, right? Synchronized cardioversion. Okay, now tell me, doctors, SVT management. SVT management. I will quickly explain like this, otherwise it will take time, right? If we go with the emergency questions. Tell me, doctors, if it is SVT, how we should manage. SVT, first of all, you need to understand what the patient is stable or unstable, right? If the patient is stable, how you should start the treatment? The algorithm is stable patients SVT management. You have to start with the vagal maneuver, right? Vagal maneuver, we have what? We have different types of vagal manuals. We have Valsalva, the standard Valsalva, the modified Valsalva, and we have carotid sinus massage in pediatric population. We have ice water immersion, right? Ice water immersion. So standard Valsalva, now we are not using, we are using, but we recommend modified Modified Valsalva over the standard Valsalva. So what is modified Valsalva? Patient in semi recombinant position, that is mean like 45-degree here, the recombinant position. Then we asked the patient to blow into the syringe. 10 cc syringe, we asked him to blow. Then move patient after the blowing. We are moving the patient supine position and perform at the 15-second passive leg raise, 45-degree here, like that. And then you have return position to patient to the semi recombinant position for 30 seconds, right? Most of the cases, this is enough to reverse the SVT, right? So another one, carotid. We are usually not doing carotid massage, but because for that we need the very well trained doctors for that, right? And I saw immersion for the doctors who are doing the pediatric population, right? If the Valsala manu fail, what you need to, okay, there's a patient, the patient with SVT, they have already tried Valsala maneuver and it has not working, and the patient is asthmatic patient. What you can do as a next thing, Valsalva failed, what you can do? Mm-hmm. Okay, why not adenosine? Why not adenosine? Because the next thing is adenosine, right? Why you should not given the adenosine? Why going with the verapamil? Why? Why? Because the patient is asthmatic, right? So the second line is the adenosine, right? If vagal maneuver failed, but we should avoid in asthma or COPD with wheezing, right? So adenosine. If the patient does not have asthma, in that case, we can give, if the Valsalva maneuver fail, we can give adenosine. Adenosine, the how you should give, doctors. We have give it as a rapid IV push, right? Rapid IV push with rapid saline flush. So dose is 6 milligrams. Then after 2 minutes, we can give 12 milligrams. Then 18 milligrams if we need it, right? So continue ECG and BP monitoring, right, doctor? So then, yeah, if the adenosine is ineffective, adenosine is contraindicated, in that case, you have to give verapamil. But before giving verapamil, you have to make sure this is only a SVT, not a VT, okay? Not a VT, because why? The verapamil can slow the heart rate and drop the blood pressure, which can lead to the severe hypertension if it is VT. So they already have the cardiac output is compromised, because that is ventricular tachycardia. In that case, if we give verapamil, that patient can cause the shock, right? Because of that, we should first confirm it as properly SVT without giving verapamil, right? Again, verapamil can give if the patient with the asthma, right, doctors? Okay, so metoprolol tartrate, when we are using metoprolol tartrate, it's giving an alternative to verapamil if Valsalva and adenosine fails, right? It's like an alternative for the verapamil. Okay, if refractory cases present, refractory mean the vagal maneuver, adenosine escalating dose in 6 to 12, 18. And second line drugs, verapamil or metoprolol, tartrate, everything is failed. In that case, so it is remain is ongoing without these options in its first line, second line, and the third line options is have like not useful. Everything as well, we call it refractory. In that case, we have options like DC cardioversion, IV amiodarone, overdrive patient. Mostly, we are going with DC cardioversion. And other than that, if the patient is unstable, we are directly go with the DC cardioversion, right? Here is the unstable SVT management, immediate synchronized DC cardioversion. These are the like general thing you need to remember. Then, okay, we'll discuss about atrial fibrillation. That is the other very important thing. Atrial fibrillation. So atrial fibrillation management depend on what? So in atrial fibrillation, what are the management you need to remember? Because these topics are very, very much repeating. Like every month they are repeating. That's what I want to explain. Tell me how atrial fibrillation management we should do. In atrial fibrillation, how? We have a management plan, right? We need to control the rate as well as the rhythm, right? We have rate control and the rhythm control. Okay, so, what is the acute management? If the presentation is less than 48 hours, what you can do, you have to do the rate or rhythm control, right? Rate or rhythm, it depends. If it is more than 48 hours, so unknown case, you have to avoid cardioversion unless 3 weeks of anticoagulation, no. Transesophageal echo is negative. I'll explain what. First, I will go with the rate control. We are using beta blockers, diltiazem, verapamil, digoxin. These are the add-on drugs. Mainly remember the beta blockers and calcium channel blockers. That is very important. Okay. In the beta blockers, we can use atenolol, metoprolol, the what for the rate control in atrial fibrillation. And here, other than beta blockers, we have non-dihydropyridine calcium channel blockers, diltiazem, verapamil, like that. Digoxin for rate control of atrial fibrillation as an add-on drug. It's not a first-line drug for the treatment of AFib, but because it may not control exercise-induced tachycardia when you sit alone. If beta blockers, so this calcium channel blockers do not control heart rate in the patient with both atrial fibrillation and heart failure, whom other drugs contraindicated, how may need be introduced very slowly. This beta blockers, in that case, we can add digoxin. Okay. The rhythm control. This is the main important thing. For the rhythm control, we are using right electrical cardioversion and pharmacological cardioversion. Pharmacological cardioversion mean we are using antiarrhythmic drugs, right? We are using flecainide, amiodarone, right? And those things. Okay, here. This is the most important thing about the rhythm control. Rhythm control depending on the time period, right? So if it is less than 48 hours, so patient is present in less than 48 hours, can do immediate cardioversion or cardioversion, either pharmacological or electrical, right? Electrical cardioversion. So if it is more than 48 hours, you have to first consider anticoagulation first to prevent the thromboembolic. So why? Why if and more than 48 hours matters? Why? What is the reason? What is the reason, doctors? Why? Very important. Mm-hmm. Why? Because after 48 hours, right, the risk of atrial thrombus forming is very high in the left atrium, right? It's very high. That's why we are not initiate. Firstly, there's thing. First, you have to exclude the embolism risk, right? Then you can give the treatment, right? Then you can give the treatment. How you should exclude? How you should exclude this right atrium, the embolism formation risk? Like, is it happened or not? How to do it? How to do it, doctors? Here, do not cardiovert immediately if it is more than 48 hours. Risk of left atrial thrombosis is high. First step, give anticoagulation. Start DUAC or warfarin or unfractionated heparin or low molecular weight heparin depending on the eligibility. Therapeutic anticoagulation must be for minimum 3 weeks before cardioversion. Or we have two things. Or you can exclude thrombus with transesophageal echocardiogram. How if the transesophageal echo shows the no atrial thrombus, cardioversion can be done earlier, right? Okay, here. Okay, 48 hours, more than 48 hours. Then, if TO is available, you can immediately do the TOFN. If there's a no left atrium thromboembolism, then you can go with cardioversion, right? Okay, if Vinny's TO is not available at the moment, in that case, you have to give 3 weeks of anticoagulation according to the patient's eligibility. Then later you can do the cardioversion, right? So we have two options if it is more than 48 hours, but you are waiting for the cardioversion. You can do the rate control, right? Because the both are in the atrial fibrillation management, right? Like that. Okay, while waiting to the rate control, control ventricular rate with beta blockers, the same thing we just discussed. Then the cardio version after safe pre-period or after excluding the left atrium thromboembolic risk, right? Here, electrical or drug cardioversion only after 3 weeks anticoagulation or TOE negative for the thrombus. Then this is another important thing. Continue anticoagulation for at least 4 weeks after cardioversion. Very important. And here you have to think about what? I have to think about stroke prevention as well. Okay, a stroke prevention according to the CHATSWA score, right? CHATSWA score. And here, now we are using chat voice score, right? Not chat var score, because in the here still we are having chat var score, but now the emergency has mentioned we are using chat var score, chat voice score. Okay, right, Doctor Tassin is Doctor. Yeah, I think right, Doctor Grace. Because we have find out during the Dr. Amrit, we have find out during this is, but still the TG has mentioned chat was okay, but we are going with now chat was go according to the medicine. Yes, we have find it out during the our exam week, not exam week, the recall revision sessions. So yeah, these are the most important thing. VFSVT, then what else? Ventricular tachycardia. What are the other things? Okay, 1 minute. Mm, 1 minute, doctors. Just give it. Yes, so the like arrhythmia, important. Mm, my sweet is stable angina. Yeah, atrial fibrillation we just discussed, right? Okay, heart block management, heart block. Okay, what is the management of first degree heart block? What is the management of first degree heart block, doctors? What you need to do? The management. So, first degree AV block, okay? So, usually you don't need any treatment, right? You don't need treatment. If the patient is asymptomatic, bradycardic symptom present, you can consider by giving atropine, okay? That is one thing, and but I want to show something. Oh no, I have not attached here. Yeah. I remember there's a one question in eMedicine for the first degree heart block, first degree AV block. 1 minute. Every time I'm telling it, but I can't still not remember. Okay, bloody arrhythmia. Okay, here the question 59-year-old woman is brought to the ambulance to the emergency. First episode of palpitation lasting 20 minutes associated with the hot flushes and nausea. She described the palpitations and found in heartbeat which came on while she was cooking. There's no associated chest pain or dyspnea and her symptoms have now completely resolved. She has a medical history of hypertension, dyslipidemia and anxiety. Medications include enalapril and the rosuvastatin. She is a non-smoker. She does not drink alcohol. On physical examination, she appears well. Pulse rate is 90, BP 135 by 85, respiratory rate 16, SpO2 98, temperature 36.8. Cardiovascular examination normal. ECG shows the heart rate 90, regular rhythm, P wave present, normal QRS. PR interval is keeping with the first degree AV block. Blood tests including the troponin, hemoglobin normal. So what we can do? What we can do here, doctors? What about the doctors? Quickly tell me, because this is very important. Most of doctors remember this question because I was telling every day when I was doing when I'm doing these sessions. Try quickly answer, doctors. Quickly. Doctors, what about Dr. Grace? Dr. Shrenika, Dr. Shambika, you should remember this one. What about Dr. DA? Is it A or is it C? Mhm. Okay, why not reassurance? Because when we are doing the first time, most doctors went with reassurance. Why? Hereby, as many patients present with the AD while sinus rhythm is important to take to the including the nature, frequency, rhythm, and intensity of the palpitation. The above scenario, the palpitation, the patient is having some symptoms, right? So spontaneous, there's no hemodynamic compromise. Factors which point to the acute coronary syndrome, blood work is normal, and no patient's admission. Like admission for observation and symptoms reoccur, admission for telemetry. Thus, arrange 24-hour monitor with GP follow-up is appropriate if required. Subsequent cardiology referral could be considered. Reassuring patient and discharging is dangerous as this patient is having palpitations have resolved. Further workup as the investigation should be done thoroughly as is the patient's underlying cause, right? So that is the reason. So keep these points in your mind. Okay, I was here, right? So at this part also in here, okay, if the patient is having some palpitations, you can consider atropine that they have given in the in TG, but remember of that question as well. If that question is going, go with the GP follow up and the monitoring of this, right? Monitoring. So next one. Second degree AV block, Mobitz 1 or Venkapac. So usually asymptomatic, no treatment needed in most cases, but if the symptomatic bradycardia present, you have to give atropine, right? Atropine 0.5 milligram IV every 3 to 5 minutes up to maximum dose is 3 milligram. Remember this part is very important. The maximum dose of 3 milligram, very important, okay? Stop any of any drugs that may be worsening the block. Then second degree AV block or Mobitz 2 management is patient, right? Because even in asymptomatic cases, this type need patient because they are high risk to progression to the complete block. So you have to treat the reversible causes present. Otherwise, you can consider temporary pacemaker first, followed by the permanent pacemaker. If it is a third degree AV block, if the patient is unstable, in that case, you have to go with the temporary pacemaker. You give adrenaline or IV isoprene if patient is delayed or not available here. IV adrenaline, IV atropine or isoprene. Atropine also here considerable as that's like a miraculous drug for the bradycardia. In this case, temporary pacemaker, if this is pacing delayed, in that case, you can think about adrenaline and isoprene because they have given a question in emergency as well. If the patient is stable, you have to go with the permanent pacemaker. 1 minute, I'll show. No, I have not attached. Sorry, doctors. Yeah, I have not attached that question. Yeah, not that. But here they have. No, not here. I hope you get the idea. And that is like those are the like main important points that you can remember, right, doctors? So yeah, we can finish the session now, right? Yeah, because you also need some time to revise. And yeah, I think most of doctors has gone already, right?